Good evening, everyone. Thank you for joining us for our webinar event about the Weill Cornell Medicine Fibroid and Adenomyosis program. It's wonderful to have so many participants. We're excited to share our program with all of you tonight, and hopefully after the webinar, you'll have a better understanding of fibroids and adenomyosis and the exceptional care we provide women with these conditions at Weill Cornell. I received many questions by email. Hopefully throughout the talk, we will answer most of them, if not all of them. For tonight, our focus will be on the patient experience, but next month we will be hosting another webinar for physicians, but you are more than welcome to join that as well and continue to send us questions that may have gone unanswered tonight. We are your co-moderators for this evening and co-executive directors of the program. I am Dr. Jayan Shin. I'm the director for minimally invasive gynecological surgery at Weill Cornell Medicine. And later on, you'll be hearing from my esteemed colleague, Dr. Mark Schiffman, assistant professor of interventional and vascular radiology at Weill Cornell. I would like to start off by acknowledging a bill that was introduced this past month, the Uterine Fibroid Research and Education Act by Senator Kamala Harris and our very own New York Congresswoman Yvette Clarke. This is by no means to politicize tonight's talk, but I wanted to highlight the importance of this legislation, which demonstrates that there is a recognition for the need on a national scale for improved equitable access to high quality health care for women, including millions of women whose health and lives are impacted by common gynecological conditions such as fibroid and adenomyosis. We developed our program to optimize the patient experience for women with these conditions and with the goal that every patient we see feels fully informed about their disease and treatment options so they can feel empowered to make the right decision for their care with their doctors. Our mission is fourfold. First and foremost is to provide accurate diagnosis and comprehensive counseling for patients with fibroids and adenomyosis through a multidisciplinary approach, provide individualized care for these conditions in a safe environment, facilitate fibroid and adenomyosis research to improve clinical care. And lastly, at Weill Cornell, we are very proud of our unique approach to fibroid and adenomyosis treatments that we hope can serve as a model to other physicians and practices. What we mean by our multidisciplinary approach is that every patient we see, their specific management and treatment plan will be discussed not only with their gynecologists, but also with interventional radiologists who will even more thoroughly counsel patients about uterine preserving options such as uterine artery embolization and MR-guided ultrasounds, which Dr. Schiffman will go into in depth. And we also have fertility specialists who we regularly collaborate with, as well as nutritionists, pelvic floor therapists, and integrative medicine physicians who we can refer patients to for a holistic approach to care. Why is a multidisciplinary approach important? Well, studies have shown that these advantages include a decrease in adverse events, improved patient outcomes, improved patient satisfaction, and can enhance coordination of care. So this is a good time to introduce our core team. As you can see, there are many of us with distinct responsibilities within the program. I'm so proud to work with our interventional radiologists and gynecological surgeons who are part of this program, who are nationally recognized leaders in their field. As many of you, I'm sure, have experienced as a patient, sometimes it's good to get a second opinion. At our program, you can be assured that there will be an abundance of opinions to ultimately come up with the best plan for you. In addition to individual collaborations, we also periodically come together as a group to review imaging studies and discuss management of complex cases. And as an academic institution, we support the practice of evidence-based medicine, and that all our faculty are current with the research literature, and that we adhere to recommended safe practice guidelines. So we recognize that patient attitudes have changed during this time of the pandemic, maybe with respect to readiness for surgical treatment, willingness to see a doctor or come into a hospital. Keeping these things in mind and respecting them is what also makes our program so unique. Patients will get same visit consultations with both minimally invasive GYN surgery and interventional radiology. At some point, at least one visit is necessary in person for a physical examination. Otherwise, patients can request telemedicine, video, or phone visits. If it's more convenient for you to get an MRI or an ultrasound closer to your home, we can arrange to have those images sent to us where they can be, again, evaluated by our own radiologists here at Weill Cornell. And we can also arrange for you to have MRIs and ultrasounds the same day as your visits as well, if that's what's needed. So I wanted to go ahead and just start giving some background information of these conditions. Fibroids are benign, non-cancerous growths of the smooth muscle of the uterus. They do not increase the risk of uterine cancer and very rarely develop into a cancer. There are fibroid-like cancers of the uterus called leiomyosarcomas, and they're not thought to arise from existing fibroids, but cancerous growths from the smooth muscle of the uterus. Fibroids affect up to 80% of women before the age of 50 years old, and it is the leading cause of hysterectomy in this country. Up to 200,000 hysterectomies a year and 30,000 myomectomies are performed annually in the United States. And what's frustrating to both providers and patients who suffer from them is that we don't fully understand the causes and why they recur. But the thoughts are that fibroids are linked to estrogen and progesterone. The abnormal cells in the uterus may respond differently to these hormones, and there can be familial and genetic predisposition as well. Adenomyosis is benign invasion of the endometrium into the myometrium. And typically what we see with adenomyosis is that someone might come in with an ultrasound that essentially is normal, except the uterus is slightly larger than normal. Okay, so it can lead to an enlarged uterus. This affects up to 80% of women later on in the reproductive years, closer to 40 to 50 years old. And again, the cause is not clearly defined, but risk factors include multiple pregnancies and also previous uterine surgery, for example, multiple C-sections. It's important to note that not everyone needs treatment for fibroids or adenomyosis. These may be incidental findings when you get an imaging study for something else, and now you're worried, you have to do something about them. It is useful to get a proper diagnosis and baseline evaluation with your GYN. However, up to about 30–40% of women with fibroids actually have severe enough symptoms that it's impacting their life and well-being. However, when patients present with these following symptoms, it's important that they seek care. And these include abnormal uterine bleeding. This can present as heavy periods, prolonged periods. You might have some spotting in between periods. You may be sometimes skipping months of periods, and then the next time you get your period, it can be extremely heavy and painful. Women with larger fibroids and certainly adenomyosis, if it's large enough can cause bulk pressure symptoms, including urinary frequency and urgency, because the fibroid might be pressing against the bladder. You may also experience lower back pain if you have a large fibroid that's pressing against your sacrum. Pelvic pain and painful periods is common, especially in women with adenomyosis. And sometimes this can be confused with endometriosis, another common but serious condition that needs thorough evaluation. We have patients who are referred to us because they're planning for pregnancy or planning to undergo IVF. And not every woman with a fibroid will need say surgical management. It really depends on what type of fibroid you have, what size, where it's located. So if you look at the schematic here on the side, there's several different types of fibroids. You could have a pedunculated fibroid, which is attached by a thin stalk to the surface of the uterus, a subserosal fibroid, which is still in that superficial layer, and intramural fibroids, which are more in the bulk of the uterus, the muscle of the uterus. And then you see submucosal fibroids. These are certainly fibroids you'd want to remove in the case for planning for IVF or pregnancy, because they can lead to pregnancy complications as well as other symptoms, including bleeding. Imaging and the physical exam are important aspects of the evaluation. These help us determine the size of the uterus, the number of fibroids, their location, everything we just discussed about the different types of fibroids that can exist. And having an idea of really how big this mass is makes a difference in terms of what kind of surgery or what procedures you would be a good candidate for. So say someone is referred for a uterine artery embolization for a 23 centimeter fibroid uterus. Decreasing it several centimeters over several months may not be enough to reduce the symptoms that you have, especially with bulk pressure or bleeding. And a hysterectomy or a myomectomy, which is where we just remove the fibroid, it may be a better option. And Dr. Schiffman and I have collaborated on cases such as this. With MRIs, they're great for visualizing fibroids. You can see in these three pictures. On the far left is a large 10, 12 centimeter fibroid. The one in the middle, she has a few more. And the one on the far right, you know, this is what we call sometimes the gumball uterus. And for these patients, no matter how much they might desire a minimally invasive approach, it might not be feasible or safe to remove every single one of these fibroids. And in that case, an open approach might be better. So imaging really kind of helps guide one fibroid mapping to determine these characteristics of the fibroids, but also with surgical or interventional procedural planning. So every woman that comes to us presents differently. Her symptoms, symptom severity, the disease burden, and because of all these differences, at our program we strive to individualize care to take into consideration additional concerns that may be influenced by several factors. For example, is surgery necessary in your case? Or if it is, do you want to avoid surgery? So what are the other possible options for you? And again, not everyone needs to have treatment for their fibroids. So how bothered are you by your symptoms? And what are your fertility plans? Are you interested in uterine preserving options, or are you interested in definitive management, such as hysterectomy? Or sometimes it might just be a short period of time that we need to provide treatment to basically get you over that hump and tie you over until menopause. I know a lot of women are anxious about this stage in their reproductive life. However, symptoms from fibroids and adenomyosis typically improve significantly once you reach menopause. And so are surgery or interventional procedures necessary? We might be able to give you medications that might improve your bleeding symptoms or decrease your fibroids. And then as you progress towards menopause, you will continue on your own to feel better. So what are the treatment options available here at the program? Basically, we offer everything, and it's important that during your visit, we systematically go through each of these options for you. So there's medical management, which includes both hormonal and non-hormonal therapies. These include estrogen progesterone pills, basically birth control, contraceptive pills. It can have estrogen in it, or you can be given progesterone-only pills if there are any contraindications to taking estrogen. There's the IUD, specifically the Mirena IUD, which is a progesterone-releasing intrauterine device. Many of you may have heard of Lupron, which is a GnRH agonist. And what this does is to help improve your blood counts before surgery, but also can decrease the size of your fibroids temporarily while you're on the medication. And tranexamic acid is a medication that can decrease your bleeding that is a non-hormonal therapy. The newest FDA-approved medication that just came out to the market maybe a month or so ago is a combination pill of elagolix, which is a GnRH antagonist, with estradiol and norethindrone. The name of this pill is called Orion. And what studies have shown is that women who take this medication can have significant reduction in heavy menstrual bleeding associated with fibroids. Now, if medical management isn't enough to control some of your symptoms, mainly bleeding symptoms, because they're not typically given to shrink the fibroids. In fact, fibers can grow on these medications. Then the next step would be interventional procedures, which Dr. Schiffman will discuss, including uterine fibroid embolization and also MR-guided focused ultrasounds. And for some women, they might want to skip both these therapies and know that they want definitive treatment with hysterectomy, or that they are planning fertility in the future, or might not want to have their uterus removed, but just the fibroid itself, and that is a myomectomy. All our surgeons are highly skilled in both laparoscopic and robotic options. If you have a fibroid that's just within the cavity causing some of your symptoms, we can do a hysteroscopic approach. For patients with adenomyosis who do not have pain, but bleeding is the main issue, we can do a hysteroscopic endometrial ablation. Or if you have a small fibroid within the endometrial cavity, we can perform a hysteroscopic myomectomy. There's almost no downtime. You go home the same day for all these procedures, even for a laparoscopic or robotic myomectomy, even for very large fibroids or very large uteri. You typically go home the same day, and recovery is within anywhere between 2 to 4 weeks. But by the very next day, we hope that you're walking around and having minimal pain. The newest technology available is radiofrequency fibroid ablation. And what this is where it's still a surgical procedure, but your surgeon makes 2 tiny little incisions in your abdomen, just like you would have for a laparoscopic or robotic myomectomy or hysterectomy, except you only need 2 small incisions, whereas the other surgeries would probably require 3 to 4. We use a laparoscopic ultrasound that helps us to target the fibroid during the surgery. And as we target and identify these fibroids, we then penetrate the fibroids with this very thin instrument that has these electrodes at the end, and those electrodes are activated and heat up and destroy the fibroid. And you can see shrinkage over almost immediately to several months, and also symptom relief anywhere during those 2 times. Okay. If you are planning to have surgery, it's really important that you look into getting a minimally invasive procedure. It's very well established that there are multiple benefits of minimally invasive surgery over open surgery for the same type of surgery. These include faster recovery, less operative pain, less adhesion formation, decreased infection risk, shorter hospitalization stay, less blood loss, improved cosmesis, and the list goes on. Here in this schematic, you can see that these are the tiny incisions that are required during this surgery that are typically 5 to 8 millimeters. So I wanted to end my portion of this talk with about 45 seconds of surgical video. So this is fair warning that if you do not want to see any of these live surgical videos, that maybe you take a bathroom break or something right now. So this first video is a typical surgery with multiple fibroids. I believe this woman had anywhere between 7 to 9 fibroids. And I'm just showing all the different locations. The one here in the back is deeper into the muscle. The ones on the surface you can see as well. And this is a very rated G version of what a myomectomy might be like. We incise that uterine tissue overlying the fibroid, and you could start seeing the spongy white ball that we slowly separate from the healthy uterine tissue and remove them one by one. Now, many patients ask me, especially if they have larger fibroids, how are you going to get this out through a keyhole, which is your belly button, or close to your umbilicus? And I thought maybe this would help clarify. Basically, once we remove the fibroid from the uterus, we then extend the incision around the umbilicus just a little bit and slowly extract the tissue contained within this bag always, so that no fragments are left behind. And you could see that with time, this piece just keeps getting longer and longer and longer, and that's how we remove the fibroids, as well as the uterus. Okay. I'm now going to turn over the talk to Dr. Mark Schiffman.
Okay, thank you very much. So that was a great overview of some of the minimally invasive surgical options that we have. And I'm going to tell you about some of the minimally invasive interventional radiology options that we have. So basically, one of the things that is important to us at the center are that patients get the best diagnosis possible. So we send all of our patients for MRIs. And the MRIs are important because they tell us how many fibroids, how big the fibroids are, and no two patients are the same. Everyone needs a plan that's based on their anatomy. So it tells us where the fibroids are located. Are they in the lining of the uterus? Are they outside? And also, sometimes it's not even fibroids. So there are other conditions that can give similar symptoms. So, at our center, we make sure we have the right diagnosis before you go to the operating room or you go to an interventional room. So as far as one thing...
Could you just put it on the presentation mode if possible?
Sure.
Just so everyone can get a bigger view of your slides? Sure. Thank you.
Yeah, unfortunately my computer keeps freezing right now. So I'll keep going until my computer unfreezes, but it's still not on presentation mode. So basically, one thing that we commonly do are a lot of my patients, they've had many, many series of IV iron infusions. And one thing that we're in the process of publishing are, we see on the MRIs, this is a spine of a patient who's had multiple iron infusions versus this is a normal appearing spine. And what we see is patients are getting iron deposition in their marrow cavities, in their bones. So you know, when patients are trying to recover from their anemias, the bone marrow is where the red blood cells are made. So one of the things that we have to start thinking about are the longer term consequences of this. We send all the patients, as we said, for MRIs, and as part of that, we include these blood vessel sequences, which Weill Cornell is kind of a leader in the world in this type of imaging. And what we see on the MRIs actually helps show us exactly what we're going to see in the procedure rooms. So sometimes we see from the MRIs, there's a polyp or some other thing that might be causing the symptoms that we could treat. Sometimes we see endometriosis, and then sometimes we see adenomyosis. So I include this slide because this is a normal appearing uterus on MRI. You could see the lining, which is bright white. Then there are three layers, white, a thin dark layer, and then a lighter gray layer, as opposed to this, where we've lost the three different layers. And these patients have severe bleeding and a lot of severe pain. So this patient came to us and there was a fibroid right on the inside of the uterus. So we just had the gynecologist remove that and her symptoms were fine. So the MRI is important. As far as the things I'm going to talk about, uterine fibroid embolization and something called MR-guided focused ultrasound. So embolize means block the blood flow. And our field's been embolizing things for decades. Uterine fibroid embolization was first discovered in the 1990s, and it's really been studied and improved such that as of 2008, the American College of Gynecology says that every patient that has fibroids that goes to their gynecologist for a consult should be told about embolization. Unfortunately, that only happens in about 30% of the time. And I recently published this in New England Journal from our experience that most patients are told about their surgical options, but not their minimally invasive interventional radiology options. So one of the things that's great about working at Weill Cornell is that our gynecologists are very passionate about giving patients all of their options. So this is what the interventional radiology room looks like. This is a low-dose X-ray camera, and we have screens. Now we actually have very large screens. It's a very nice setup. And basically, the uterus and all the fibroids get their blood flow, their main blood flow, from an artery on each side called the uterine artery. So what I'm able to do, through a needle stick, I don't make any incisions, this is all needle stick, I'm able to feed a catheter first into one uterine artery, and then afterwards negotiate it into the other uterine artery. Once my catheter is in a good position, then I actually take a microcatheter, which is a tiny catheter, which is smaller than a millimeter, similar to the one I've used in the brain. And then we're able to start injecting these little particles. The blood flow carries the particles to the blood vessels that feed the fibroids. And this is the key to the whole procedure. I have these particles in all different sizes. If I'm embolizing a liver cancer or kidney cancer, and that's what I used to do at New-York-Presbyterian, I use the tiniest particles to fill in every blood vessel. We don't have to do that for fibroids. The fibroid arteries are much larger than the normal sized arteries. So we use these larger particles that fit into the fibroid arteries, but they're too big to block off the normal arteries. So we're able to fairly selectively block off the fibroids, but we can leave the whole uterus alive. That's how the procedure works. This is the example in the procedure room. Through a needle stick, I take a catheter up one side, down the other. Inside, we take a microcatheter deep in the uterine artery, inject contrast. This is all the blood flow to a fibroid. I start putting the particles in and I stop when I've pruned off all the flow to that fibroid. Once I'm done on the other, I go to the other side. Catheter, microcatheter in the other uterine artery, inject contrast. This is the abnormal fibroid blood flow. I put the particles in and I stop when that's been blocked off. But you can see the uterine artery and the normal branches are still open. It's because these bigger particles can't block them off. So that's the whole procedure. As far as after the procedure, we'll go into that, but this is an example. So here's a 53-year-old. Here's a large fibroid uterus. The white is the urine in the bladder. You can see how this is all pressing down on the bladder. That's why these patients, they don't sleep through the night. They have to go to the bathroom. They try not to drink because they don't want to have to run to the bathroom. By 3 months later, the bladder is able to go from this, as this shrinks down, back to a normal size. This black stripe here are the stomach muscles. You can see how they're being bulged forward. as the uterus shrinks down with time, it's able to go back to being flat again. Here, the uterus is rubbing against the spine. That causes back pain. As this shrinks away, that goes away as well. And then finally, here's the colon. So there's space for the colon back here, but there's no space between the uterus and the spine for the colon to get up into the abdomen. So it's like stepping on a hose. Everything gets backed up and bloated, particularly when the cycle comes. As this shrinks down, there's a lot more space for everything. So we're not cutting these out. This is just a needle stick in the leg, but we're going to kill the fibroids and then they're going to shrink down. This is before contrast, everything is gray. This is after contrast at a patient that I embolized. You can see the uterus is still turning brighter from the contrast, but the individual fibroids are all dead, including these tiny little seed-like ones. So the beauty of the procedure is there could be 20 or 30 fibroids. I don't have to put a microcatheter to every fibroid. The blood flow carries the particles to all of the fibroids. So I've had patients who've had 1, 2, or even 3 myomectomies. It's not because the fibroids came back necessarily, but the ones that get left behind, then they have all the access to hormones to grow. So we're frequently able to kill all of the fibroids in one treatment. Here's another patient. The top of the uterus is up here, and this patient's only symptom was bloating and constipation. So there's room for the colon here, but there's no space. The top of the uterus is here. By 3 months later, the symptoms have resolved. The top of the uterus, which is up to here, is now down to here, and there's more room for everything. So that's the idea. Again, this is the bladder. The white is the urine in the bladder. Goes to a normal size again, and patients are able to sleep through the night again. So, we could show many of our follow-up images. We can frequently shrink the uterus between 30 and 60%. However, sometimes, as in this case, we can shrink it 80%. This is a patient that had had a prior surgery, a big open myomectomy, and she had some issues with bleeding in the operating room. So the second time, they wanted to try an embolization, and she said, this is beforehand. This is the same slice afterwards. The uterus is not even in the image. So one thing that I like to show on this image, there should be 2 circles here, an artery and a vein. This uterus is so large, it's compressing the vein. So what does that cause? That puts patients at risk for forming blood clots. So a lot of the symptoms of fibroids, frequent urination, bloating, those things are quality of life things. Blood clots can actually be a medical emergency. You can see as this shrinks away, here's the artery, and now the vein is open again. So that's one of the most important things to come away with this. If anyone is starting to have leg swelling, or is anyone taking a long plane trip, a long car ride, you should be wearing compression socks if you have a known fibroid diagnosis. The fibroids push against the veins, and veins are floppy. They could compress. So that slows the blood flow, and you're at risk for blood clots. So as far as the follow-up, I said that the uterus gets its main blood flow from a uterine artery on both sides in the pelvis. However, fibroids are very resourceful. Sometimes they're not getting enough blood flow from the uterine arteries, and they're able to grab blood flow from elsewhere. For instance, here's an artery coming down from the abdomen, and it's coming over and feeding the fibroids. If I didn't embolize this as well, there wouldn't be a good result. So any hypervascular mass, and I treat liver cancer, kidney cancer, you can't treat 2/3 of it and expect a good result. Fibroids, they're benign, but the same thing. You have to find their blood supply and you have to block it. This is one that I found off a lumbar artery feeding a fibroid. So what we get is we get those MRAs that we talked about, and you could see how beautifully the MRI clues us in to there's another blood supply. And this is what we see in the operating room. It correlates perfectly with the imaging. So part of having the best results are having the best imaging and preparation. As far as complications, so embolization is a very safe procedure. The complications, particularly the major complications, are extremely low. This is from an early article published in 2000. At this point in time, our infection rates are less than 1%. Bleeding is almost unheard of. As far as any bleeding or damage to the artery, that's much less than 1% as well. And as far as readmission or ER visits, these numbers were in 2000. I think I've had 1 or 2 patients in the last 10 years come back. And that's because if patients could be having some nausea, they can't keep their pain medicine down. So overall, it's a very safe procedure with very few complications. As far as what patient care is involved, the gynecologist and the interventional radiologist, we should be working together. You know, we should be figuring out what's the best treatment. Do we need any types of biopsies beforehand? And what is the schedule that should be happening, which takes into account what your preferences are. So as far as the embolization, for bleeding, for fibroids, I'm at 95% successful. As far as the bulk symptoms, depending on the size and location, up to 87% successful. So patients frequently ask, are the fibroids going to come back? If we're able to kill the fibroids, dead is dead. They're not going to come back. Depending on your age and your genetics, is it possible you could develop additional fibroids and they can have time to grow? Yes, it is, but everybody is going to be an individual case. Okay. As far as fertility, that's something that is a huge question, and that's something that we don't have very good evidence from. There's been thousands of healthy, normal pregnancies after embolization, but that's not the same thing as me saying that it can have effects. That being said, we don't have data that surgery improves fertility, except for fibroids on the inside of the uterus. That's just what we've done at this point in time. At this point, I think it's a fair statement to say it doesn't seem to close the door to fertility. I've had several patients who've had healthy, normal pregnancies. I had a 56-year-old woman bring in her newborn baby to meet me. So, you know, this is something that we're going to be at the forefront of trying to help learn as much as we can going forward. So as far as the advantages with the embolization, we could treat multiple fibroids. It's a minimally invasive procedure. The recovery period is a week. Patients walk out the same day, but there's some cramps and there's some low-grade, like flu-like feelings that go on. And, you know, I talked about the patients in consultation. You know, I tell them exactly what to expect, exactly what the time course we expect it with. As far as the procedure, there's minimal, if not no, blood loss during the procedure. I do this procedure in patients who present to the emergency room bleeding dangerously. We have a lot of patients who will not accept blood products and have very low hemoglobins, and we're still able to very safely do this procedure. As far as the procedure itself, there's no general anesthesia. There's no tube put down your throat for breathing. The nurse starts an IV. We give you a couple of medicines through the IV, but the procedure itself doesn't hurt. The only thing that you feel is a tiny lidocaine needle to numb the skin. Once the skin is numb, you shouldn't feel anything during the procedure. And it generally takes me about 25 minutes to do the procedure. I do 3 or 4 each day. The ones we do in the morning, go home the same day. The ones we do in the afternoon, we observe overnight and go home the next morning. So I'm going to skip through a couple of these things because we also want to talk about another condition that we treat, and that's adenomyosis. And that's something that patients are frequently told that they have fibroids, and then they come to us, and on the MRI we say, actually it's not fibroids, you have adenomyosis. And that's something that's very upsetting to a patient to hear, that for years she's been suffering and not had the correct diagnosis. So one of the things that when fibroids, and you saw from the videos, you know, fibroids are very discrete balls of tissue, so the surgeons are able to remove them. For adenomyosis, this is tissue that's infiltrated throughout the uterus. So there isn't really a very good surgical option other than hysterectomy. However, embolization also works very well for adenomyosis. And I'll start showing some of my case results. And basically this was from 2011. And you can see a very enlarged uterus with these little white dots of tissue. It's the lining that's been implanted. And after the embolization, the uterus is probably about 40% smaller, and more importantly, her symptoms have completely resolved. So, and this is something that I learned with time. Originally, it was thought that embolization didn't work for adenomyosis, and that's because they were using the same technique that they used for fibroid embolization. When I talked about it in the beginning of the talk, we said that there's different size arteries. Fibroids have large arteries, so you could use the large particles. If you use those exact same particles, you're not going to get into the vessels feeding the adenomyosis, and you're not going to kill any of that tissue. So I started treating these much more like I used to treat the liver cancers and the kidney cancers. I have to try to kill some of that tissue while leaving the whole uterus alive. So that's something that we're able to do. This is another very dramatic result. You could see all of this dark tissue. The patient's abdomen is bulged forward by the uterus. And by 6 months later, here's the bladder. Her bladder is back to her normal size. The uterus is back to her normal size. The abdominal muscles are flat again. And most importantly, her symptoms had resolved. And the adenomyosis symptoms are very dramatic. Patients have severe pain. The bleeding, it could be unexpected and it could be profuse. Patients frequently have accidents in public. They're really suffering quite a bit with this. Here's another procedure. And again, adenomyosis could be throughout the whole uterus. This patient, it was mainly here on this wall of the uterus. And within, this is about an 8-month follow-up, we were able to kill all of that tissue and the uterus is back to a normal size. You can see the colon here comes to a point because there's not a lot of space here. Now the colon actually has room. So the bloating improves, the frequent urination improves, and the heavy bleeding and pain resolves. So, and here's another one. So basically, it's not every once in a while I get a patient that gets a great response. No, the procedure works. We just have to tailor it, and we'll work to publish our techniques going forward. So you can see the bladder here, and then the bladder in the follow-up. And it's something that a lot of the embolization patients, that they don't even realize that they haven't been drinking and they're dehydrating themselves, which is not healthy for the long-term kidney health. They just do what they have to do in order to go about dealing with the fibroid symptoms. So finally, I'm going to talk a little bit about focused ultrasound. And this is a very exciting technology that we have. And we're the only center that has this technology. And basically, we're able to aim an ultrasound beam that's hooked into an MRI machine. The ultrasound waves come together at a point and burn that point. So while I'm watching on the MRI, the patient slides into the MRI machine. We're able to look at the fibroids, make a target, and then get a burn. So this is completely non-invasive. Patient lies on the table, and there are no needles, there are no scalpels. This is just, we're aiming ultrasound beams through the skin. So basically, we need an MRI to see if the patient's a candidate, if someone hasn't had surgery, or the fibroids aren't close to intestines, then they might be a candidate for this. So these are the things we talk about when we see you in consult. Sometimes a fibroid is here, we can't aim through a loop of intestine to get to here. So this is a very exciting technology. I've been using it. We have a prostate cancer protocol, and quite frankly, I think it's the future. For fibroids, I think it's one of the many technologies that we have available to you. So we're able to see the fibroid, make little treatment planning grids. I can put little stops where I don't want any heat to go, and then I could watch where the heat is being deposited and get a full burn. Okay, so these are some of our images. We see the fibroid, we can get a full burn of the fibroid. And then, we could do larger fibroids as well. So basically, what's unique about coming here? So as I said, every patient is unique, your anatomy is unique. So it's not either you have to get surgery or you get interventional radiology. For example, this is a patient that had had a hysteroscopic myomectomy. And when the fibroids get large, when they put a camera into the uterus, they have to stop at some point. this patient came to me. She had had the myomectomy and her symptoms were still there. We got an MRI and it looked like they had just taken a bite out of this fibroid. So the gynecologists, they have to stop when they've used a certain amount of time and fluid. So what we did is I embolized the patient, and then the patient went back to the OR and they were able to take the whole thing out. So that was in 2013, and since then we've done over 100 patients that way at our center. So the best care is when different fields are able to work together and come up with a solution for each patient, and that's what we take pride in. So again, we've actually taken out some very large fibroids through the cervix, you know, as an outpatient procedure by doing it in combination on the same day or separately. So that's unique in the world. So as far as conclusions, fibroids, like my colleague said, they're benign. There's a genetic predisposition, and only if patients have symptoms do they need any type of treatment. So one of the things that we're proud of, the skill level of all of our operators, and also we all work together so that everybody gets to see both the gynecologist, interventional radiologist, and then we both discuss each case to try to find the best treatment. All right. Well, thank you very much. This is one of my patients after. And basically, this webinar is going to be recorded, and we will send you a link to the video in case you wanted to watch it again and again and again. Or also, if you wanted to see us in consultation, you can book an appointment for the Fibroid Center. The phone number is listed right here. All right. Thank you very much. And now we're going to go to question and answers.